I'm good, you?
Are you here to steal coffee?
Yeah, like usual. Today we're operating on a 13-year-old boy with osteosarcoma, a high-grade cancer of his tibia. The odd thing is his illness had very few warning signs.
Yes?
Has my patient Emilian arrived?
Not yet.
Will you call me back, please?
Yes.
Thanks.
He's just arrived, Sophie.
Okay, thanks. This is a situation that makes every family a bit hypochondriac because the kid was in great health, with no pain, then got a painful limp, and suddenly an aggressive underlying cancer was found. Hey, has he arrived? Did you give him his CD?
Yes.
He's already had 3 months of chemotherapy, which were extremely hard. He had complications with his skin and his mouth. He struggled to eat. He was malnourished. He had pressure sores. His catheter got an infection. Thanks. We knew it was going to be hard. I warned his family it was going to be hard, but I didn't know it would be this hard. How are you? Thanks for the CD. As promised, I bought you 2 kinds. I brought barbecue flavor and regular Doritos. All right? I bought 2. When I operate on a child or a teenager, one of the things I've started doing to try to brighten up the day of the surgery is ask them what their favorite junk food is. What would they really like to eat most of all? It always makes them smile on the day of the surgery. Often with the patients and their parents, even if they're very emotional because I'm taking their child in for major surgery, it always gets a laugh.
Can we eat them while we wait, or?
That would be terrible. I can't allow that. I realize that works really well. I'm just checking your leg to make sure it's ready for surgery. Very young patients get to me a bit more. I mean patients who are the same age as my children. Teenagers who are a little older than my children are my favorite patients. I love talking to them. I try to build a rapport with them as much as possible. Usually I can close the skin. If I can't close the skin,
You'll take that.
I'll take a little skin graft.
I listened.
Yes, you remembered. That's the important thing. Emilian is a wonderful teammate. He's extremely bright. He asks the right questions. He's switched on about his treatment. He knows what's coming next. It's hard to put a child through this, but I always bear in mind that we're here to cure him.
I'm going to get the patient.
Good luck in surgery.
Hello, ladies. How are you?
Very well, thank you.
We ask a lot of our patients. Actually, their illnesses ask a lot of them. Is Mathieu there?
Mathieu has arrived. He's gone for blood tests. After, I'll send him to 12 for transfusion if necessary. We're not sure yet.
Okay. Today we have an external clinic, so it's a pretty busy day. Hello? Hello, Miss Longpre. How are you?
I'm fine.
You're fine?
Yeah.
How was your weekend?
Great.
Today there's a grade 1. That means the patient will have a transfusion with treated cells to develop anti-tumor immunity. These are cells from your donor. You already know each other?
My sister.
Because your donor is already here. These lymphocytes are like Superman cells because they've developed the ability to recognize leukemia cells if they're present and hopefully destroy them. The patient has acute myeloid leukemia. She had initial treatment and a follow-up, and unfortunately, she relapsed. So we're going to give her this cell treatment. The danger when we give you these lymphocytes is you could develop graft versus host disease, which you've already had. It's where your donor cells react to you. So there could be skin reactions like red blotches and itching. There could be nausea, diarrhea. There could be problems with your liver, which happens when it's acute. And there are other potential risks we can't determine. When we decide to become doctors, our first principle is not to harm the patient. Clearly, we take side effects into account. However, if those side effects lead to a cure, survival and quality of life, I think it's a path we have to take. We're going to ask for the cells to be brought up, and then we'll start the adventure, Ms. Longpre.
I'm ready.
You're ready?
Yeah.
We're ready? Excellent.
Hello. Today is the start of my 2 weeks on this floor. This morning, I saw we had 34 patients, so I need to get to know these 34 patients so I can take care of them over the next 2 weeks. Hello. How is your breathing? You look quite good.
I'm having the same trouble.
But you're still having trouble, aren't you?
Yes. Yeah.
It's hard to judge quality of life. This lady has chronic obstructive pulmonary disease caused by smoking. It's a terminal illness where she gets out of breath easily in everyday life. It's going to be harder and harder to go home, right? What are we going to do?
I don't know.
Because your disease is progressing.
Yes.
These patients struggle to get rid of their mucus. As you heard, she coughs, but she's congested, so that increases the risk of respiratory infections. She shouldn't come in just because she's more congested as she moves around more at home, but often she comes in with pneumonia or bronchitis, which requires antibiotics. You'll have to ask yourself, because you're always coming into the hospital.
I know.
How many times has it been since January?
9 times.
9 times?
Yes.
That's more than once a month that you've come to hospital. When we speak to her about her treatment, she wants to be intubated. The year before, in intensive care, she was put on a ventilator. So in her case, it's clear that if she needs to be intubated, she wants to be. If things get worse, what will we do?
I don't know.
The last time we spoke, you were doing worse. You'd like us to do everything, go to intensive care and put you on a ventilator, but I don't think it's a good idea.
No?
Your lungs are so sick that if we put you on a ventilator, we might have to do a tracheostomy after.
Yeah.
For her, it's life at all costs. She really wants to live, even if she can't get out of bed. Sit up, I'm going to listen to your lungs.
Asseyez-vous, je vais écouter vos poumons.
Being a doctor means being able to serve. It's being able to listen to someone, analyze a problem with them, and try to figure out a solution. How did the preparation go?
I'm in agony. Oh my God. I want it to be over. I'm tired.
The patient we're operating on today came to hospital a few days ago for abdominal pain. It was investigated, and they found appendix cancer with peritoneal carcinomatosis. So the cancer has spread to the surfaces of her intestine. It's an extensive disease. It's stage 4 cancer. In any case, we'll see you again just to reassure you.
Will it be around 4 or 5 hours?
4, 5, 6, 7, we don't know.
6, 7? Oh my God.
It could be 7 or 8, but you won't know the difference. Then we'll call your husband. We don't have any choice but to do potentially extensive surgery right away to remove this disease, and to do chemotherapy during surgery. We're going to try to cure this patient. The procedure we're doing today has a 40% risk of complications, which is huge. That's probably 5 to 10 times more than any other surgery, including heart surgery and chest surgery.
Have a nice day.
Thanks.
Thanks.
We know when we'll start, but not when we'll finish.
She's going upstairs. I'm meeting the family. He's going upstairs.
Okay, fine.
Good. Today is going to be a bit more difficult. We have patients with extremely critical and unfortunately irreversible conditions. Damage that's spread to the brain, people with no chance of recovery. It isn't something we can cure. Ma'am, are you ready?
Yes.
I need to go see the families to discuss the patient's futures. We have to distinguish between what the family wants, what the patient would have wanted, and what's doable. I wanted to meet with you because we've gotten to an important step in his treatment. We have a patient who until recently was completely independent, young, and healthy. There was an accident. You don't wake up from this type of coma because there's damage on both sides. He won't be able to speak or eat. He won't be able to do those things anymore. The problem is there's nothing I can give him to make him any better. Naturally, these moments are extremely delicate and emotionally charged. What do you think he would want? If he were sitting here with us, what would he say?
He loves life.
But does he love this kind of life?
No, that's true. He's suffering.
We have to see what's realistic. It's an open discussion where the family is the patient's voice.
Well, I can tell you that a month ago, my father was very conscious, and what he wanted was to live. That was his answer.
If he'd been told that his life now would be like this, always in bed, never able to go home, never to do the things he did with you, do you think he would have given the same answer?
That I don't know.
There needs to be time to understand and a transition period, especially for someone who's never seen this before. If we touch him or speak to him, there are reactions.
When he opens his eyes, it's like he doesn't see anything.
It's more of a reflex. He reacts, and he'll probably react to your voice, and that will make things harder for you. I understand they need time to come to terms with the fact that he won't wake up, because we all want our loved ones to get better.
Well, I think the fact that he's going this way will also help prepare the family. That's important to us.
Dr. Robards? Hello. Did you see the radiation oncologist? And?
He didn't do anything to me. He wants to make an appointment.
You were coughing up blood. Now it's under control. We don't know if it'll come back.
Coughing up blood. I've been doing it for 5 months.
Yeah, that's it. But at some point, you could cough up so much blood that it'll end up flooding your lungs. This patient was coughing up so much blood, his life was in danger. He was put on a ventilator, even though he had previously said that he didn't want that. But the chart wasn't available at the time, so when he got to the emergency room, that was done. And the surgeon, while looking for options for the patient, reviewed the literature and saw descriptions of cases where that treatment had been used, so he gave it to the patient. We can offer you an experimental treatment.
Yeah.
They'll give you radiotherapy on the parts of your lungs that are bleeding.
All right.
But that's the opposite of what you were saying last week when you didn't want any more treatment. Are you ready to go every day for 2 weeks to get radiotherapy treatment?
Yes.
It's really difficult to care for a patient and figure out his treatment plan when there are contradictions in what he's saying. You wonder, does he understand what he's deciding? Does he really want to start this treatment when last week he didn't even want any more medication to treat his problems?
My son takes care of my case.
He'll speak to the radiation oncologist. I'm going to speak to your son, okay?
Yes.
During Emilien's surgery, we're going to remove a large part, around 5 inches of his tibia, and replace it with a prosthesis. We're replacing his knee with a mechanical knee. This surgery will change his life because there are certain sports he won't be able to play anymore, such as contact sports. His tumor is 0.8 inches. 0.8 inches. The chemo seems to have worked. On the MRI in the operating room, the swelling around the tumor appears to have gone down. The tumor is smaller than it was before chemotherapy, so we know it's having an effect. I just want to look at it.
Yeah, that's it. If Sophie is going to look over your whole body, let her look.
What was that?
We know Emilien's portacath got infected before. Portacath is where they inject the chemotherapy or parenteral nutrition. It isn't infected. When I removed the dressing, there was some discharge that wasn't necessarily infected, but I didn't feel comfortable leaving it there. Get me a syringe to clean it. It worries me because we know one of the main complications with tibia prostheses is infection. This...
I know. That isn't what you wanted to see this morning.
No, it really isn't.
I am not happy with this at all.
Hello, this is Dr. Lachance. Listen, there are 2 donors who have agreed to let me see them. A patient who receives a transplant, either a stem cell transplant or an organ transplant, is a patient who will get treatment for the rest of their life. Mr. Pilon, how are you?
Fine.
You're fine, are you? I sense some hesitation. What's bothering you?
A little cough.
This patient received an auto-transplantation, which means he was his own stem cell donor to treat his lymphoma. I'm not worried about him medically. The transplant went well. He's recovering. And recovery can be difficult, depending on the patient and their expectations. The reason you're still a bit tired and short of breath is you're still anemic. It's just a question of time. In theory, it will take 4 weeks. After a month, we'll start to see a slight rise in energy levels.
Okay.
I know for someone active like you, it's difficult.
It's high season for me. I'm a horticulturist.
I understand. We see patients who are very affected by their transplant, weakened, and finding it hard to live every day with the limitations imposed by their illness and treatment. Your immune system needs time to recover.
It's so far.
Why do you say that? What's troubling you?
Well, it's because I was on sick leave for 2 years, 10 years ago.
Yeah.
And now I'm going to be off sick for another 2 years of my life.
We're not planning to put you on sick leave for 2 years. It can be an extremely difficult time to get through. It's a long process, and the complications can make the process after the transplant very hard to bear.
Major illness. A GIA will be necessary. Before being able to make a decision on the spread of the disease, you need the full picture of what's happening in the abdomen. You have to understand that the exams we do are not perfect. In 10 to 15% of cases, there are surprises that force a change of plan during surgery. The touchiest part is the right cupula. That will be around noon, I think. Our first step is to clean, quote-unquote, all traces of cancer. It takes a long time. If we leave a small nodule, less than an inch, that we missed, the procedure we put the patient through is doomed to fail. The big veins in the stomach are always posterolateral, right of the arteries, even on the left, okay? There are places in the abdominal cavity where dissection can turn into a nightmare in 5 seconds. If a vein is cut, it could be fatal for the patient. Something is bleeding here.
Can you hand me that, please? The metal, the prosthesis I'm going to put in, is like a sponge for infections. I took the time to do an initial surgery that wasn't planned, which meant reopening his portocath wound, cleaning it aggressively, and closing it up so that he doesn't develop an abscess in the area over the next few days. Needle? Good. Okay. That's good. Can we send the sample? We removed the tumor. It went well. So the tumor has been sent to pathology for analysis. It went well.
Okay. That's good. So the tumor's gone, right?
Yes. It's really important to put the parents at ease by giving them news when we can. Now the rest of the surgery will be a piece of cake.
Is it too late to give this to you? No. Do you want me to put it in the recovery room?
Yes. Okay, that's fine. I'll bring it to him. It's going well. We might change stages and start reconstruction. That will take at least 2 hours. I'll come get you when they say to come get you, all right? Okay, bye. Hey, check it out. Super Groot. Oh, I want one. He's cool. It's for my patient.
In intensive care, you might have a day that's perfectly planned out, but things happen. One particular thing is patients can be candidates for organ donation. His brain, like you said, has come down. It's called herniation. You can see it's like a big gray mass, and that's a bad sign. It's a sign of serious swelling in the brain. It's probably one of the hardest things to learn and to tell the family, because there's nothing that can prepare you for that. An image like this can't tell us if he's brain dead. All it can tell us is his brain is extremely damaged. We need more testing to prove it. And that's the apnea test. The last thing that stops in a human being with brain damage is breathing. That's why we call it an apnea test. The test will confirm or rule out the diagnosis of brain death. I'm going to do it, then I'll come back. We can definitely give them some time. We'll be delicate, but there's still the pressing question of organ donation. Brain death is the final point of no return. The brain is completely destroyed and doesn't work anymore. It means that at the worst moment, or near enough, when the family has been informed that their loved one is dead, while the patient doesn't look dead at all, I come in and ask them for the greatest act of generosity possible, saying, "Do you consent to organ donation?" Because there are people whose lives this will save. The criteria for brain death are the criteria for legal death. From then, there are two options. Either we go for organ donation, or since the person is deceased, we stop and the machines are unplugged. Now the patient is officially dead, even if his heart is still beating. Because the heart doesn't need the brain to beat. That's the odd thing. For the family, you can't rock the boat any more than that. What's difficult is he appears alive when you look at him, even though his brain is completely dead. Sometimes, the organ donation process offers some consolation to the family, because in the absurdity of what's just happened, at least there's someone, somewhere, who has a second chance because of the donation. Death is transformed into several lives. Organ removal tomorrow. You said the heart will go to Quebec. The liver has been assigned to Royal Vic.
Hello, Mr. Lafleur, Dr. Lachance, how are you this morning?
I'm good.
You're donating to your sister, who's already in the hospital upstairs, I think?
It's my birthday today.
Are you serious? It's your birthday? Well, happy birthday.
It's a coincidence.
His sister is going to receive the stem cells he donated today. She'll get them tomorrow. When stem cells are donated to a patient, we say it's a rebirth. So it's a new birthday. So there's symbolism. Hello, Mr. Gagnon. I'm Dr. Lachance. How are you?
Really good.
You're doing well? Did you have any pain on the weekend from your injections?
Back pain, especially my vertebra.
The vertebra.
My shoulder.
Is your shoulder sensitive too?
Yes, yes.
But were you able to take some pain relief medicine?
Yeah.
Okay. Putting your life on hold, receiving growth factor injections, and spending all day at Maisonneuve-Rosemont with bone pains to donate stem cells. It's a completely altruistic donation. It gives me hope for humanity when I see that someone is prepared to do that.
Okay, it's here, bleeding here. Okay, we passed it, but it's still bleeding. When we do surgery on a patient with cancer, our strategy must take into account how we can reconstruct the patient's body part afterwards. Our aim is always to reconstruct the most normal body part possible. There are limits you can't go below because it won't work. The ovaries will be affected, but I think the uterus will be saved. When parts of the digestive tract are removed, we must then make anastomosis, connections between both parts, for it to work. Every time we make a connection, there's a risk of a leak, an abscess, or that we might have to put in a stoma bag because to treat those complications, that's often necessary. So the risks add up.
How's it going, Pierre?
It's going very well, but now there's some bleeding to get under control. We don't take any decisions lightly during surgery. We know that when we do something, there might be a consequence, and we might be forced to do something else. We need to know if the patient would want us to do this other thing, and if it's reasonable. We're always asking ourselves questions. We have the rectum, the right colon, the right appendage.
The bladder's in position.
We've removed a nodule from the bladder, but it will be okay.
Good.
The reason this procedure is so high risk is because we're combining an already major surgery with chemotherapy, which gets in the way of healing. Actually, that's how cancer is treated, by destroying the repair mechanisms of cancer cells. So everything heals worse due to chemotherapy. When we do intraperitoneal chemotherapy, it's direct chemo, which means it's 1,000 times more targeted than chemotherapy infused into the veins.
How much time is left?
7 minutes.
After 30 minutes, we remove the chemo to stop the chemo from getting inside the blood and producing effects that could kill the patient if left in at a high dose.
Okay.
Mr. Donnet-Giroir, room 26. Treatment is our patient's best ally. I mean, even if the treatments are hard, they have to get on with them to have a chance of getting better and eventually being cured. Mathieu, when we last saw each other, you looked like you were running away. What happened then?
Yeah.
Were your knees hurting?
My knees, yeah.
So you have intense knee pain, and that means you'll be unable to do anything.
Yeah, often. When I lie down, my knees get swollen and hot. Then I get a fever.
Okay. We can never predict 100% whether a patient will progress favorably or whether they'll have a potentially dangerous complication.
Yes.
What's most draining for you, Mathieu, is the pain. I understand. Okay. Does it wake you up at night?
No, because it's not bad at night. It starts in the morning.
That's true. When you load up, when you start to use. Okay. Mathieu, a young man with an aggressive disease, acute lymphoblastic leukemia with mediastinal damage, received a second transplant a few months ago now. And it's been hard on him. We don't want him to suffer so much physically, so we'd really like to solve the problem he's having with bone pain. We want to make sure it isn't a symptom of a disease.
Whenever I try to do any little thing, I get severe pain the next day. So I don't know if even super easy physio would help.
Yes. We always want to do more. Could I do more? Right now, I don't think so. I think we've really pushed ourselves to the limit with what we can offer Mathieu. Be careful. You're not allowed to fall, okay?
Yeah, no, I won't fall. I'll make sure I don't fall.
Good, good. See you, Mathieu.
See you.
As a pathologist, my aim is to make sure I've removed everything. I want the tumor to be in the bone canal. Then some of Emilien's bone would be normal up to the incision.
Yeah.
It's just 0.4 inches. That's right, but I don't think it's much. 0.4 inches isn't much. I was expecting a margin of 0.8 inches in the bone. I have around 0.4 inches, so I'm going to remove a small layer of bone to make 100% sure that any disseminated cells are removed at the same time. The problem is it's custom made. I can't make it longer. The prosthesis is 4.7 inches. I've accepted that Amelian's leg will be 0.1 inches shorter than the other. But at least I'll feel comfortable knowing the tumor has been fully removed. I'm cutting at 4.7 inches, but that gives me just 0.4 inches of room because the tumor spreads to there. Do you see what I mean? I need to take a bit of tibia. A leg that's 0.1 inches shorter is a minor detail in my opinion, because the long-term goal is for him to survive the disease.
It's gonna be short.
Okay, so basically it's just gonna make you cough.
The patient was put under for surgery. His lymph nodes were removed. His surgeon discovered a much more advanced cancer, which meant totally revisiting his treatment plan.
It's gonna be okay.
We need to inform this patient that his cancer is much more advanced, and that what he thought was relatively minor surgery, with few after effects, is in fact going to be major surgery with a drastic effect on his quality of life afterwards. We're talking about removing his entire voice box. He'll breathe through a pipe in his neck. He won't be able to talk.
Okay, I'm gonna turn on the lights.
I have suction. I have one.
Okay, perfect.
It was extremely hard to intubate him due to the swelling around the cancer. Now I need to remove the tube that's keeping him alive, because we want to get his opinion. We want him to be able to speak to us. We want to talk to him.
Take a deep breath, and here we go.
All right, just spit it out now. Cough everything out. Yeah, perfect. Spit it out. Good. And that's it.
It's difficult to measure someone else's suffering. Someone who has very good reasons for wanting to live at any cost may not be able to take a great deal of suffering. Experience has shown that we must be open with others and talk things through. Through conversation, we'll figure out what does or doesn't make sense. Are you okay?
Yeah. Now take deep breaths, okay? And there's a little fog, okay, in that mask. That's normal, okay? It's just gonna help you breathe.
It's hard, without consent, to presume the patient's response. We don't necessarily know their values. We don't necessarily know what their thoughts are. Even if there are significant consequences, we don't take it for granted that a young patient would want this surgery. But he said no. The surgery he turned down could potentially cure him. Not just prolong his life, cure him. But he isn't prepared to do it. It's his life. If one day I were in that situation, I hope my doctors would respect my decision.
We're gonna talk about everything this afternoon, okay? But we have a plan for you, okay?
And for now, you just stay in the ICU anyways, okay?
Ms. Gauthier? Hello, I'm Dr. Chagnon. We met in the ER.
Yes.
You're a little better than when I saw you, aren't you?
Yes.
I'm glad. This lady has terminal cancer that we can't cure. She has decided not to carry on with chemotherapy, which could have improved her chances of surviving for a few months, but wouldn't have changed the outcome. It wouldn't be able to cure her cancer.
I'm more than ready to go.
More than ready?
I'm taking space from someone else.
But you look good. I'm relieved, because when I saw you in the ER,
I was in agony. I was in pain all night.
I think that if we quickly make the patient comfortable, they feel confident that they'll remain comfortable in the end. They'll be better placed to cope with palliative care confidently. It's clear that she's confident that things will be okay. That's why I think she's so calm. You're in good company.
Very much so.
You'll be fine.
Yes.
Aren't you worried?
No, not at all.
Are you ready?
Oh, yes.
Well, all right. I'll look at things and try to arrange for you to be discharged tomorrow, because what you need is to be home.
Abdominal wall surgery should be done. We're definitely in a better position with this patient than yesterday to consider her chances of full recovery in 5 or 10 years, because the surgery went very well. We were able to remove the whole tumor. We know that for the type of cancer she had, which we managed to remove today, she has a 75% chance of full recovery. The patient will be pleased. To find out if she's cured, we'll have to wait 5, 6, or 7 years, but her chances are very good. Her life has probably been saved. Pressure is stable. We'll wake her up gently. She's curorized. We'll remove the tubes here before going to the recovery room.
Okay, perfect. Thanks a lot.
The average survival rate for cancer patients before intraperitoneal chemo was developed used to be 9 to 12 months. Now, depending on the type of cancer, the recovery rate, when we've managed to give the entire treatment, varies from 30 to 80%. So, it's an incredible breakthrough for those patients. How was it? That's normal. We worked everywhere.
Oh my God.
You don't have a bag either. No need for a bag. You just need to recover slowly, okay?
Thank you.
Bye.
So, Melanie, we often give lymphocytes like this. The only difference is this is the first time the lymphocytes have been treated in this way. When we administer them, usually we don't need to be next to the patient. If there's an emergency, we're just a few steps away. However, in this case, since it's the first infusion and these are lymphocytes that have been treated, there's always a risk of a serious reaction to the infusion. If there are any problems, we can react quickly.
Melanie Longpre?
Yes?
The receiver is GCS and the donor is A positive.
Exactly.
She's taking a risk for her health and her life. When cells are used, there are patients who have severe and serious reactions that bring them to intensive care. Allergic reactions. We're starting the infusion. The moment the treatment is administered, we're opening a window to a new therapeutic approach. It's really about putting faith in the unknown and pushing past limits and barriers. Are you okay, Ms. Longpre?
Yes.
How do you feel?
I feel fine, but I'm a little emotional.
It means a lot to you. You're right.
Sorry.
It's okay. It's okay. It's okay. It's normal. I understand. It's okay. I think she understands that this is a last resort for her, hence the emotion. We're placing a lot of hope in this.
Yeah, a lot.
For me, the patient's emotion is a request for reassurance. I take it as a potential sense of accomplishment. If the treatment is effective, her leukemia won't come back.
Mr. Cote, hello, I'm Dr. Chagnon. We've met. I gave you the injection.
Oh, yeah? Here for another?
It's possible the water will keep coming back.
Yeah, I know.
We'll ask the surgeon to put in a permanent drain.
Yes.
Like that, you won't need to get an injection every time.
Yes.
This patient hasn't recently been diagnosed with cancer. He has already had chemotherapy. The disease has come back and progressed. This morning when I saw him, he was having a lot of respiratory discomfort. I wanted to solve his respiratory problem. While looking at his chart, I saw no long-term plans had been drawn up with him yet. It's important to make them better, but also to figure out, if we don't manage to make them better, what the next steps will be. Are you short of breath today?
The longer it goes on, the worse it gets.
Yeah, you look very short of breath. When I saw you...
I've done nothing.
Right, but last week you weren't short of breath at all.
No.
I think when you're short of breath and in discomfort, it's clear that you want relief. I was looking at your chart. You were treated by people from palliative care, but you were at home.
Yes.
Do you live alone?
No, with my wife.
Are you thinking about going home?
Well, can I go home like this? No?
When I removed the liquid last week...
Yes.
Were you okay after? Well,
Well, I was more comfortable, but not...
Not perfect.
Oh, no, no.
Okay.
If there's nothing to be done, palliative care, medical assistance in dying, and that's it.
But we can help relieve you of your symptoms. I'm going to try to make him see, what if we make you feel better, so you can spend time with your loved ones and be more comfortable for your final weeks? Would that be an option? Then he'll decide. But if we don't make it clear that there's another option than to end it now, I think the decision will be less informed.
Does that mean I'll suffer for another 2 or 3 weeks or a month?
Yes, that's right. You're the one who will decide if it's acceptable or not.
Okay.
If it isn't, you can talk with your wife.
It's all done and over with.
You can talk to us again and we'll follow steps for medical assistance in dying.
Okay, perfect.
But I think you should know there are other options. We'll follow your lead.
Okay.
All right?
Perfect. Thank you very much.
I'm very pleased. Very pleased. The skin feels loose. There's no tension. I'm pleased. We had great skin to close up with, so there was no need for a skin graft. Being able to close his wound without tension cleanly was hugely satisfying. So that has lessened my anxiety about the coming days. Finito, Pepito.
Finito.
Yeah. After the operation, I'm eager to tell the parents if it went well or if there were any minor complications.
Did it go well?
That was number one.
Okay.
Done.
Cool.
No graft. Simple closure. Yeah. Their anxiety level falls drastically when they know the treatment went well. Now they can move on to the next thing, the rest of Emilian's treatment.
Check. We can move on.
Check. Check number one.
Yes.
Actually, check number two, because check number one was chemo. Check number two, we'll see how it goes. The worst thing is hiding things from the family. I tell the family exactly what happened. I had calculated that there should be at least 4.7 inches of normal bone before making the incision. I had calculated 4.7 inches. I had around 0.4 inches. I cut around 0.2 inches of bone. That means his leg is currently 0.2 inches shorter than the other. I don't care at all. I don't care at all. You know, even if he grows up to have 0.2 inches difference between one knee and the other, he'll never notice. The other thing I want is to be sure the whole tumor was removed. 0.4 inches would have been tight. If he had a reoccurrence, it would be a disaster. Parents often have a hard time imagining life with a child with after effects. But they have to understand that living with a child with after effects is better than living without that child. His little Groot is cute, right? When I went to see Emilian in the recovering room, I was pleased. With tibia prostheses, a lot of things can go wrong unexpectedly, and today it went well.
Great, you're a champion.
We'll know Emilian's prognosis in the next 3 months. If everything goes really well, he'll be able to not play professional soccer, but play with his friends in the schoolyard without a problem. He's extubated. He's not very awake yet. The nurses will come and get you soon.
Thank you. Have a good night.
Bye. See you tomorrow.
I have good news for you. We have been able to remove all the cancer, and she will not need more chemo after that, so the treatment is complete. Yeah, I understand that. I'm happy for her.
Today's been a great day, but it's like I've run a dozen miles.
Good. See you tomorrow. Bye-bye.
I'm physically and mentally exhausted. But when that exhaustion is crowned by success, it's very rewarding. Finished.
Have a good night.
Bye.
See you tomorrow.
Saving someone's life is extremely fulfilling for me as a surgeon. Today was the perfect day.
Bye. See you tomorrow. If a patient has had enough, it's also very rewarding to make them feel better, to make them comfortable, and to free them from all this heavy-going treatment. Sometimes you also need to let them know that doing nothing is an acceptable option.
What brings light into my life on days like today is probably the sense that I've done something in someone's life. That's what makes us get up every morning, arrive at 7:30, and spend 12 or 13 hours in hospital without watching the clock. Then we get home, and we're happy to come back the next day.